Hi guys, hope you're well. Welcome to day 5 of the Aurora AKT 30-day challenge. Every day for the last 30 days up to your exam, we're doing a live question that you do in real time just to get you under that time pressure, followed by a bit of teaching from a knowledge point of view, but also the all-important technique point of view as well. Thank you to all of you who have commented on our previous 4 questions. Really glad they've been of some value to you. If you know of any other colleagues or trainees that you think may benefit from these challenge videos, please do send them the links. Please do put up things in WhatsApp groups, Telegram groups, Facebook groups, or wherever you think there may be other trainees or colleagues who will find these free videos of some use. But I'm really glad that you're finding them some of value. Today is another clinical question on shoulder pain, very common presentation that we see in primary care, and again some bits that are going to come out from a knowledge as well as a technique point of view. So if you haven't seen these videos before, we go silent now for 57 seconds when you have a think about a question, have a think about the answer, and then we'll come back and do some teaching on the other side. So without further ado, let's move into the question. Let's get my timer ready. Off we go, 57 seconds. Okay, again, that is time. 57 seconds. Goes fast, right? 57 seconds. There are some questions where 57 seconds is loads of time. You know, say you get a simple question where you have, I don't know, a presentation and you just got to basically work out what's the most likely diagnosis, or you've got a condition and you've got to think about what's the most likely treatment. Those are much easier than these type of questions where you have to read quite a bit and get both knowledge right and technique as well, and things that maybe confuse your mind a little bit. So let's go through this. In a morning surgery, you've assessed 4 different patients with shoulder pain. Which of the following statements about management of shoulder pain is most inaccurate? First thing, from a technique point of view, there's a double word there, right? Most inaccurate. If you keep most inaccurate in your mind, as you go down A, B, C, D, E, it starts to confuse you. Okay, A, is that most inaccurate? Okay, B, really that's true. Is that most inaccurate? C, so by the time you get to the bottom, you're thinking, okay, hold on, which was the most inaccurate one again? And you have to go back and read them all again, and that is where you get energy sapped, and that is where time takes the better of you. So change that to a single word. Make it very simple for your brain. Which of the following statements is false? False is much easier to remember. Is A false, B false, C false. So it makes it easier for your brain and takes away less energy. Now, the false statement or the most inaccurate statement is C. So well done if you got C, either because you guessed it or because of process of elimination, or if you knew it inside out. Well done. But C is the answer. This is a false statement. No more than 3 corticosteroid injections should be given for the management of rotator cuff disorder. So if you look at NICE UKS, then the guidance is pretty clear. No more than 2 corticosteroid injections should be given for the management of rotator cuff disorder. So number 1, you've got to know the number of injections. Number 2, you've got to make sure you're in the right condition, because there are different guidelines for, say, frozen shoulder in terms of injections than there are for rotator cuff disorder, etc. But C is the right answer, so well done if you got that. All the other statements are accurate or true. So A, an early glenohumeral steroid injection should be considered early with frozen shoulder if no response to conservative management. So that's true. So a glenohumeral steroid injection should be considered for frozen shoulder early on. Hot packs may be helpful for adhesive capsulitis. So remember, adhesive capsulitis is just another name for frozen shoulder, so don't get confused there. That's straight out of the guidelines. Hot packs may be helpful, but again, from a technique point of view, the word may here is very, very powerful. See, that's a soft word, and we talked about this in the previous videos as well. When you get soft words versus hard words, make sure you start to subconsciously pick these up, because a lot of things may happen. So the fact that, you know, if this helps one person in 1,000, that's a true statement. as opposed to hard words, which are always and never, and they're unlikely. So subconsciously, this should be a true statement from a technique point of view, even if you didn't know that from the guidelines itself. We talked about C. D, adhesive capsulitis or frozen shoulder can be both primary and secondary. So primary is idiopathic, and secondary is when it happens alongside another condition like diabetes, for example, which we'll talk about in a second. But again, the word can here is a soft word. So start to subconsciously look out for these, or without even looking out for them, see if you can get to the point where you're thinking about them without thinking about them, if you see what I mean. And then D and E, a new shoulder swelling should be referred urgently to secondary care. That should be bread and butter. Got to rule out things like malignancies. So that should be a definite true. So the false statement, or the most inaccurate, is C. And hopefully some of you guys got that right. Now let's cover a bit about shoulder pain, because like I said, very, very common in primary care. I can easily see questions coming up in an AKT-like exam on shoulder pain. Frozen shoulder then, adhesive capsulitis, like we mentioned, a lot of these diagnoses in shoulder pain are clinical diagnoses mainly, so you've got to be spot on in terms of the presentation, the pattern of symptoms. So with frozen shoulder, you get this stiffness and you get reduction of movements generally all around, so reduced active and passive movements when you examine as well. So primary or secondary causes, like we mentioned, so it could be idiopathic, but it could be secondary to things like diabetes, trauma, cardiovascular disease. So if you get shoulder pain, and in a question, they're putting lots of other medical conditions, frozen shoulder should be higher up there because they're already slightly more at risk than somebody who doesn't have all these things. And those classic 3 phases in the story of frozen shoulder, and a question might be asking you about any one of these 3 phases. So pain initially, followed by stiffness, and eventually followed by resolution. And as you can see, it can take kind of beyond 3 years sometimes for this full passage. And a question could be asked about someone right at the beginning, all the way through to near end. So pay attention to those 3 phases. How do you manage it as per NICE CKS? Analgesia, early physio for 6 weeks. Consider that glenohumeral steroid injection early on, like we mentioned, and refer if no benefit at 3 months, or if you're not quite sure what's going on. But 3 months is the key figure to remember for referral. Quite a few differences there between that and rotator cuff disorders. Again, a clinical diagnosis, so a tear or tendinopathy, for example, based around the muscles of the rotator cuff. And you have that classic pain on lifting in that arc, isn't it? So when you lift your arm, you get that pain in the 70 to 120 degrees angle. So again, clinically should be able to pick this up. Analgesia, as with most MSK problems, physio for 6 weeks. But here is a subacromial steroid injection, and there's a maximum of 2, like we mentioned, and that's why the answer was C in this particular question. Refer if no benefit at 6 weeks. So this is different to adhesive capsulitis. So as adhesive capsulitis has that more prolonged natural history, you can see that you'd refer slightly later, because you can almost see that, okay, at 6 weeks, it's unlikely to have improved anyway, whereas in a rotator cuff disorder, 6 weeks is enough for you to think about getting orthopedics involved. Other causes then, so ACJ arthritis, particularly if you're getting shoulder pain in an older patient, tenderness over the ACJ area, analgesia, physio, steroid injection possible, but of course x-ray, particularly if you're going to be referring to orthopedics, make sure that x-ray is done. Suppose about shoulder dislocation, usually shoulders dislocate anteriorly, especially in the younger age group, but you can get posterior dislocation as well. Any question about this in terms of a first dislocation, or if somebody's got recurrent dislocation but have not seen orthopedics yet, even if it seems like a stable picture, get a referral done in terms of an answer to a question. And then, of course, don't forget other things that you need to kind of think laterally about with a lot of MSK questions, actually. So PMR, polymyalgia rheumatica, stiffness, bilateral, history of, or links with temporal arteritis type symptoms. Make sure you spot that in a question. And, of course, referred pain. A lot of joint pain is not from that joint itself. So look out for anything in the question that talks about the neck, for example, or history of neck problems. Now presenting with shoulder pain. Very common cause of shoulder pain in primary care is due to neck-related problems. So you've got to know shoulder stuff. NICE CKS has a good summary on shoulder pain, but it's something that I would certainly look into, as it would be all the key joints that we're going to see in primary care as well. Now, if you guys haven't used our audiobook courses, I know a lot of you guys already have, then a quick word about how these can benefit you in the last 27 days. These buy you time, right? If you're currently sitting there right now thinking, how am I going to cover everything in X number of days? These can really help. These allow you to learn when you're not sitting down to learn. So yes, you can sit down and do questions on question banks. Yes, you can come and read or watch our online courses. But if you want to buy the time for example, when you're commuting, or use the time when you're shopping, or use the time when you're out with the kids. These are where audiobooks help. So we designed 3 audiobooks, and there's a discount on the bundle. But if you use the coupon Aurora Video 10, you get an extra 10% off the discounted bundle. So this coupon is really important if you're going to get anything for VARs for AKT until the end of the exam, mocks, live course, audiobooks, online courses, flashcards. Make sure you use this bundle. But the audiobooks come in 3 types. Clinical, stats, and admin. These are all the chapters that come with them. You can go straight to one chapter if you want to do it in a chapter by chapter way. And you download them to your phone and you listen to them offline or online as many times as you like. There's no expiry. A lot of ST1s use these because of the fact there's no expiry and because of the fact that we update them for free with unlimited time. So you can use these for as long as you like. But go to the website, have a listen to a sample. If you haven't listened to them yet, listen to a sample first, because not everybody learns through audio. Some people do, some people don't. Some people soak it in, some people just can't. So make sure you listen to a sample. But if it works for you, then we've got a triple bundle, which is discounted. You can buy any of these 3 individually as well. But the triple bundle, but make sure you use that coupon Aurora Video 10. Really hope this has been of some value to you. Like I said, if anybody else you think might be finding these useful, please do send on links. Please do join us tomorrow for day 6. Hopefully we'll see you then. Hashtag Camp Pass Well Pass. Hashtag I went with Aurora. Have a good day.